Let me to introduce Professor Teixido. He's assistant professor of neurotology and otolaryngology of Thomas Jefferson University, University of Pennsylvania in USA. Thank you, Michael. Welcome to our meeting.
Thank you very much. I am delighted to be here, and thanks for organizing. And thank you, Sergio and Asif, for inviting me. Here's my presentation. Hopefully everyone can see that. This is a very simple presentation. It just has to do with some observations of morphology of the membranous labyrinth that have become evident to me in the development of a model for simulation of BPPV. Today I want to just review the fact that conceptual models have evolved to account for all of the many observed phenomena in BPPV, but they've come a long way. Of course, early on, this was all thought to be a problem of vertebrobasilar insufficiency until Dix and Hallpike demonstrated that you could generate the symptoms without any head on body turning. And then the thesis of cupulolithiasis was forwarded because of a couple of temporal bones presented by Hal Schucknecht. And that discovery kind of blinded us to the reality of canalithiasis, which much better fit the dictates of Ewald's laws. And over time, we became aware that not only was canalithiasis the prevalent form of otolith disease, but there were both geotropic and apogeotropic forms of otolith disease in the canals, that cupula can float and cause paradoxical findings, but that are reversible and clearly generating from the labyrinth. We have challenging patients who have multi-canal disease, and we're even now starting to explore in migraine and vitamin D causes that are beyond the obvious of age and trauma. But we do still, as observers, and as we've seen in our meeting yesterday and today, clinical cases which are interesting and which defy explanations based on the existing models, and which lead us to make investigations and thought experiments which guide further insight. I would like today to present just some observations, they're very basic, on the morphology of the membranous labyrinth, which many of us, although we see these patients all the time, may not have actually considered in detail. Just as the cupulolithiasis era demonstrated, we can be blinded by a little knowledge and dismiss incongruent information because we're blinded by what we know. And I'm going to present a detailed anatomical model that can help us to explain potentially some more subtle phenomena that we will observe when we examine patients. And of course, it's always the discrepancies between our clinical observations and model predictions that advance understanding. So I set out over the years to create a model for BPPV, and of course, not using the bony labyrinth, but the membranous labyrinth in which BPPV exists. Rindy Northrup at the Temporal Bone Foundation in Boston was invaluable because she had a collection of bones which were not, and a few of which had not had the anterior canal completely transected and discarded. And it was necessary to have a bone that had intact anterior canals in order to make a model that was going to be suitable for a histologic reconstruction that would be useful for a BPPV model. So we made this histologic model by scanning histologic sections at 100 microns, by aligning them, segmenting them, And then we made it pretty for teaching by giving it to animators who colored the canals and averaged the surfaces and smoothed them. And then we cloned our labyrinth and positioned it relative to the skull according to the standards established by Charlie Della Santina and others down at Hopkins in their excellent paper in 2005. And we can see that the angle between the posterior canals is not 90 degrees, it's less than 90 degrees. That the angle between the anterior canals is not 90 degrees, it is greater than 90 degrees. And that this is the position of the labyrinths in humans. Also, but over time, I've become, when we look at the membranous semicircular ducts, we can see that the semicircular ducts are bent toroids. They are this toroidal configured, so like a bent bicycle tire. And this toroidal configuration probably increases sensitivity over a wider range of angles of rotation. And since the inertia of fluid in the canals is a tangent function, it is relatively resistant to changes in angle, but bending the toroid does enhance it some. And you can see that the anterior canal is bent, the posterior canal a little more, and the lateral canal is the most bent of all of the canals. So I took this information that was processed in a Mira software and then downloaded it into a Unity 3D, which is a game development software, which allows many of the controls for manipulation that would be important for a 3D model. And this model allows movement. I want to see if this is going to play. This often happens in Zoom, the videos don't play. Well, this model can be turned using this a navigation wheel, and this can rotate the model in increments of various 45, 30, 10, 5, and 0 degrees. You can then rotate the model in the RALP and LARP planes. There is a registration of the specific angles for any position of the model. And you can add otoliths anywhere by touching the model and clicking. And then we can turn gravity on and off to observe migration of otoliths to the lowest dependent position. So I hope that this is a free downloadable model available at bppvviewer.com. And I encourage you to download it and play with it. But let's take a look at some of the observations. Okay, so let's look at the anatomy of the lateral canal. I want to make sure I didn't miss a slide. And when we look at the lateral canal anatomy, we know that the lateral canal has a posterior to anterior angulation in the upward direction. This turns out to be around 25 degrees, very close to the 30-degree traditional teaching. And but there is also a medial to lateral angulation of the lateral canals, which are raised about 18 degrees off of the horizontal plane on each side. And this is very important because it puts the non-ampulated end of the canal very much lower than the ampulated end, so that the canal has a tendency to self-empty. More important, though, is that the bent toroidal shape of the lateral canal divides the canal into three functional segments. There is an anterior inflection, seen at the arrow, a posterior inflection, and the three segments are the anterior, the intermediate, and the posterior segments of the lateral canal. Now I say canal, but we really should be talking about the bony semicircular duct because this is a membranous duct. So when we think about the configuration of the lateral canals, we can think about a gull wing with an upsloping to the anterior inflection and then a downsloping in the intermediate segment. And then this I think gives a good model of the actual configuration of the canals. So these are important because disease and the anterior otoliths, which are trapped in the anterior segment, give rise to apogeotropic canalithiasis clinically. The majority of otoliths are in the intermediate segment and give rise to the much more common geotropic lateral canalithiasis. And otoliths, which are in the posterior segment, self-empty and probably give rise to a phenomena which I call pseudo-orthostasis. And these are patients who rise and have dizziness on rising in the morning. This is rather pronounced, but happens only one time. Patients who have orthostatic hypotension tend to also get dizzy when later on in the day, when they rise from sitting for some period of time. But these patients only get it this first time on rising. And therefore, it's very difficult for us to observe these patients in the clinic. So here's another video. Hopefully it will play. This demonstrates otoliths, which are in each of the three segments of the semicircular duct. And I turned on gravity, and it looks like those should all, when I turn on gravity, these otoliths settle near the ampulla. The intermediate segment otoliths drift a little bit, but stay in the intermediate segment. And these posterior segment otoliths, when gravity is turned on, auto-empty, get into the utricle and actually find their way into the infundibulum of the posterior canal near the crista. So we're going to have a little difficulty while this processes to advanced slide. So the next observation is, and it's not very obvious here, but that the posterior semicircular duct is elongated. It's not a perfect circle. There is an elongation of the curvature of the duct along the floor in this segment just proximal to the cupula. And there's a lesser elongation along the superior curvature. This is in the model, and when we created the model, we were trying to be faithful, but we wanted to make it pretty. So let's look at the actual histologic reconstruction, where we can see the common crus, the posterior duct, and you can see this elongated segment. When we place a circle of constant curvature, we can see the length of this elongated inferior segment and of the superior segment as well. If we look at the model of the membranous labyrinth from the Eaton Peabody lab viewer, which Brian just alluded to as well, we can see this elongation in a rather pronounced way as well. So here's a circle of constant curvature and the elongation along the posterior, along the floor of the duct, just posterior to the ampulla, and along the superior curvature. And this may be important because this suggests some design features. A flat area in the floor of the duct where arguably most debris tends to accumulate that causes otolith disease allows for more debris accumulation without duct obstruction compared to a duct that is uniformly curved. And also, if you have debris in the floor of the duct, when you have vertical head motions, the flattened duct will allow less debris movement than one that has a constant curvature. And this may be a design feature that decreases the effect of unavoidable otolith disease. And it also, the curvature, the decreased curvature at the apex of the posterior duct explains how otolithic debris may be retained at the apex of the posterior semicircular duct, which gives rise to the recently described apogeotropic posterior canalithiasis, which is so frequently mistaken for anterior canalithiasis. So we know that some degree of friction is present between otolith debris and the wall of the duct, and that, and this is something that I think is an area that we need to study. And one of the simple engineering principles which needs to be looked at in otolith disease is the angle of repose, which can be interpreted in two different ways. And that is, first, the maximum angle at which an object can rest on an inclined plane without sliding. And so this would describe the coefficient of friction between otolithic particles and the supporting surface or the wall of the duct. But otolith mobility may also depend on particle to particle interaction. So angle of repose can also refer to the steepest angle to which a material can be piled without slumping. And this, of course, varies with particle size and particle adhesion and the qualities of the fluids that lubricate the surfaces between particles. So this is something that we need perhaps some help with from our laboratory colleagues, but even clinically, if any of us have the 3D frames for turning patients with otolith disease, these properties can be studied using that simple equipment and oculography equipment, which is omnipresent in our clinics. Now, an anatomic feature that we should be aware of is that the common crus is not vertical. It actually has a 40-degree posterior angulation. And this means that we have to lie down at least 50 degrees for the common crus to be horizontal and to exceed 50 degrees in order to load the posterior canal. So one of the, what would be a way to prevent otoliths from leaving the utricle, from entering the common crus and entering the posterior canal? Well, it seems that most of the membranous labyrinth models demonstrate some dilation of the common crus. It is not a uniform conical conduit. There's a dilation, and this dilation may act as a trap to prevent otolith debris from entering the labyrinth. If we look at the EPL viewer, we can see this, and if we look on the original membranous labyrinth, used to create the BPPV viewer, we can see this dilation of the proximal common crus as well. So this is a feature which we can consider when, as we move forward. I just like to point it out to a group of thoughtful individuals to see what may come of it. Now, we have become much more aware of cupulolithiasis clinically, and the actual geometry and orientation of Crista planes has been elusive. It is very difficult to study using histopathologic techniques because of the dehydration of the cupula which occurs. And it may be that there are going to be MRI techniques that Brian alluded to, a very, very high Tesla MRI that can help with this by measuring these in vivo. The Tagaki and Sando and Takahashi did attempt to study this histologically, and what they did report was that rather than terminating at a 90 degree, rather than having the Crista oriented at 90 degrees to the incoming semicircular duct, it is deviated from 25 to 30 degrees from the expected plane that's perpendicular to the canal axis. And that deviation tends to be toward the front of the head. Since identification of cupulolithiasis, our idea about the actual planes of the Crista and the cupula have been established clinically, not in the laboratory or by investigation, by identification of null points. To demonstrate this, the posterior cupula position, which is represented in the model, not by any imaging. I actually attempted in this model to trace a line that seemed to be on the crest of the curvature of the Crista. But each trial was so variable that it was difficult to say with certainty which was the direction of the actual plane. We know that in posterior cupulolithiasis, the null position is approximately 30 degrees from vertical, and that the Crista is well elevated off of the floor of the posterior semicircular duct. Of course, cupulolithiasis can happen on either side of the cupula, and we know that probably the greatest amount of otolith debris comes off of the utricle, enters the infundibulum of the posterior canal, and rests at the base of the Crista, where we believe dark cells play an important role in digesting and reclaiming debris. The cupula, of course, is raised off of that floor where debris accumulates and is protected somewhat by the ampullary dilation of the semicircular of the membranous labyrinth to prevent debris from landing directly on the cupula. So the null positions for the right and left posterior canals are in about 30 degrees tilted forward in the right and left LARP and RALP planes. And we see this when we see a rare patient who has posterior cupulolithiasis, who presents with upbeating nystagmus, which disappears in the null position, and then reverses to a downbeating nystagmus with the head forward of this position. Now, the most vulnerable cupula to loading is the lateral canal, and clinically we see this. We see that the non-ampulated, or that the ampulated end of the lateral canal is directly adjacent to the utricle, and that in a normal lateral sleeping position, otoliths which shed there would seem to have every opportunity to rest and embed onto the cupula. We know that lateral canalithiasis, lateral cupulolithiasis occurs on both sides of the cupula, and Kim and others in Korea demonstrated that when a cupulolith procedure, releasing procedure was utilized, you could determine which side of the cupula otoliths were embedded on, because those patients in whom the otoliths were on the utricular side of the cupula, they became immediately asymptomatic. But patients who had otoliths embedded on the canal side of the cupula, they remained symptomatic, but converted to lateral canalithiasis. And the predominance of disease was in those patients who had utricular side lateral cupulolithiasis. When we when we identify these patients with cupulolithiasis, we identify the null position, which is usually 6 to 10 degrees turned in the direction of the affected cupula. This is a contradiction with the established teaching that it is away from the affected cupula. And now our better, higher clinical acumen has demonstrated these null positions. And we can turn the patient away from the affected side, and the otolith debris moves the cupula in the stimulatory direction and causes a stronger nystagmus than in the when turned in the ipsilateral direction. When we anterior cupulolithiasis has yet to be convincingly demonstrated, and it's a little bit of a puzzle when we would have to, in order to load otoliths on the utricular side of the anterior cupula, we would have to remain in rather unnatural positions for a significant period of time. But when we are, but why don't patients with anterior canalithiasis, in which otolith debris presumably falls all the way to the ampulla, why don't these patients actually get cupulolithiasis and present with constant upbeating and nystagmus? Are most of these patients actually having a disease in which otoliths are on the crest of the anterior canal, or is the cupula anatomically shielded from these resting otolithic deposits because of the configuration of the actual cupula within the ampulla of the membranous labyrinth? That's just a question. So many of us, we all have experienced that when we do a successful canalith repositioning procedure, patients may be very ataxic. And I think we've all wondered, oh, we must have dumped a load of otolithic debris onto the utricle. And let's look at the relative position of the entry of the common crus compared to the utricular macula. The macula is actually protected up in the highest portion of the utricle, and the common crus enters at the lower end of the utricle. Many of us, because of this posterior angulation of the common crus, tend to tip the patient forward in this upright position in order to empty the common crus effectively. And this may actually enhance the ability of otoliths to disperse and land on the utricle, and causing this usually transient ataxia. I'm sure that we've all observed that. So these are just a few observations that I've made. I hope that they're interesting to you. They point out that anatomical models can offer insights into BPPV pathophysiology. We've reviewed the bent toroid shape of the canals, which in the case of the lateral canal has important clinical implications because of the 3 segments the canal is divided into, which correspond to canalithiasis variants. We've looked at the elongation of the posterior canal, which may explain a tendency to apogeotropic canalithiasis in the posterior canal in particular. We've pointed out the expansion of the common crus, which may be a design feature to protect against otolith entry into the posterior and anterior semicircular ducts. We've looked at Crista positions and how we use them clinically, and the position of the common crus relative to the utricular macula. In addition, we have looked at the angle of repose, and so that we can keep that in mind. And we really do need input from our colleagues who have the 3D treatment chairs to establish norms of otolith adhesion and motion in patients. And finally, I encourage you to download the BPPV viewer. It's free, and to play with it, play with the gravity functions, use it to make illustrations in its line drawing view. And I welcome any feedback that you have on it as we continue to improve it. So I thank my fellows and the computer science and engineering graduate students who helped to develop this project. And I thank you for your attention.
Thank you very much, Michael, for the outstanding conference. Very surprising, totally new data for us. I would like to ask you, is there some current methods in neuroimaging to see those anatomical findings that you have shown?
I really don't think so. I think that we would have to ask Brian if with it, whether or not 7 Tesla or even 15 Tesla magnets are capable of imaging finer portions of the membranous labyrinth, and whether the differential diffusion of gadolinium is complete enough to image all of the portions of the endolymph compartment compared to perilymph.
A question about the ataxia, did you find differences between age? Because we know that the patient, the older patient had more ataxia after repositioning maneuver. Do you know that?
I think I seem to see this with patients of any age, and I think that it has to do with, I think, how completely they have been avoiding provoking symptoms. And if patients have been avoiding provoking symptoms, then they may have really accumulated a large amount of debris. And when liberated all at once, there tends to be some ataxia afterward. They leave the clinic unsure of whether you've done them any good, but then they come back and they report a miraculous result.
Yes. Brian?
Yeah, so I think our current technology is not adequate to image those structures right now. You can image people in 3 Tesla for a longer period of time and increase your signal to noise, but you run up a limit of the amount of deposited energy into the tissues with your radio frequency pulses. And so there's, I think it's on its way. It's not there right now. Can I ask Michael a question too?
Sure.
So with the angle of recline of the common crus, I often have patients with recurrent posterior canal BPPV who ask, what can I do to prevent this from coming back? And I talked a little bit about the study about vitamin D, but do you ever tell patients just to kind of sleep at a 45-degree angle? Is that reasonable?
There are some patients who have, obviously BPPV is self-limiting in the majority of cases. So the patients who we see, especially when we know that we're booked out, we're only seeing chronic patients. This indicates that if they've been symptomatic for a long period of time, this tells you that they have a problem in which otoliths are continuing to shed despite partial resolution of their symptoms over time. They're continuously reloading their canals. And if they have an injured utricle that is always going to do that, or they have a utricle that is recurrently getting injured by migraine, and you can't control the migraine, then I think that avoiding otolith loading is reasonable. And most of, many of our patients have found that solution for themselves beforehand. It's the...
Can you see the question and answer box? There is a question about the viscosity of the endolith.
There are probably differences in viscosity. I'm not an expert on this, but we know that otoliths are only 60% mineral by mass, and the remainder is protein. So otoliths which dissolve in endolymph leave behind proteins, which can probably change fluid properties. And but how variable endolymph fluid properties are in pathologic states or even among normal individuals is something that I don't think is very well known. But thanks for your question.